Good afternoon, everyone, and welcome to the 2024 VBID Center Summit, Overcoming Financial Toxicity. My name is Susan Lynn Osterly, and I'm the Program Manager for the VBID Center. I'd like to go over some logistics. We would like the summit to be as interactive as possible. Attendees can send questions and comments via the Q&A tab on the Zoom control panel. Given the format of today's session, time constraints will limit the number of responses to audience questions, but we're always welcome to questions, comments, and feedback at vbidcenter@umich.edu. And now I'd like to hand things over to Dr. Mark Fendrick.
Good morning, some people. Good afternoon to others. Susan Lynn and the entire VBID staff, I can't thank you enough for all the dedicated efforts you put in to make this summit possible. Next slide, please. It is a great pleasure to reconvene. This is our 20th summit. We first got together in 2005, and some of you know, seeing the participants who've been with us from the beginning, the VBID idea was supposedly conceptualized over a $5 bibimbap at Kang's Korean restaurant. By the way, that now bibimbap is now $10. And there you see myself and my close colleague and VBID Center co-founder, Michael Chernew, sitting listening to the first summit in 2005. Next slide, please. For those of you who've heard this before, I apologize. This is my mother, who's turning 90 this month, who, when I told her after talking with Mike about the problem with cost sharing and our efforts to reduce them, she said, "I can't believe you had to spend $1 million to show that if you make people pay more for something, they'll buy less of it." Thankfully, many of you, the many collaborators and friends of the VBID Center, know that my mother was right. And thankfully, when she said, "I can't believe you had to do more studies to show that if you make people pay less for something, they buy more of it," thankfully, our mothers are always correct. So next slide, please. So for almost 20 years now, Mike, myself, the VBID Center staff, and our amazing advisory board who met yesterday has collaborated with stakeholders across the board of the healthcare continuum to identify, evaluate, and implement strategies that improve access, enhance equity, and improve efficiency of the healthcare system. And in our second 10 years, we've actually focused a little bit more on the identification, measurement, and removal of low and no value care. Next slide, please. So I'm very excited to convene this year's summit. We'll be touching on several initiatives that the VBID Center is working on with a particular focus on equity enhancement and disparity reduction. These include the preventive services provision of the Affordable Care Act and the legal threat to that provision in the Braidwood versus Beshara case. We'll be talking about high deductible health plans. We'll be talking about access to medications, and we'll have a specific panel on how hard it's been to address this issue of low value care. Next slide, please. So all of this would not happen if it wasn't for our sponsors, and you see them all listed here. We've always been particularly proud to see multiple stakeholders, from payers to health sciences companies to benefit consultants to patient advocacy groups, who support our work to reduce out-of-pocket costs and enhance utilization of high-value services. And completely coincidentally today, next slide, please, is something called Giving Blue Day here at the University of Michigan. And for those of you who might be interested in supporting the center, I've been thinking about it, you will see in the link a specific link to the VBID Center if you feel so compelled to support our work. We're nonprofit, we're tax deductible, and any size of donation will help us continue our efforts. So with that, next slide, please. I am absolutely thrilled this year again to introduce my very close friend and amazing colleague, Cliff Goodman. Cliff has been with us at the VBID Center almost from the beginning. We do not have VBID summits unless we know Cliff could be around to moderate them. We are thrilled to have you here, Cliff, today. And with that, I thank all of you for participating, the registrants, which we hope to have around 700, all the panelists who've given up their valuable time, the VBID Center team, and of course, you, Cliff. Take it away, buddy.
Thank you very much, Mark. Glad to be here and actually honored to be here with this group. And I know that over the years, we've had so many people revisit these summits, and we've basically all learned together in real time. So for today's webinar agenda, checking this out, We're going to have 4 main sessions, the first one of which is going to address high deductible health plans at 20 years. Basically, what have we learned about these plans since they were put in place 2 decades ago? There have been successes, but there's certainly been challenges. And certainly the kind of backdrop in the healthcare system has changed dramatically. So these really bear a more careful look at this juncture. The second session is going to look at enhancing preventive services use. Again, speaking about backdrop, what about the backdrop of Braidwood versus Bechara? That is pending in the federal courts. That could go a long way toward improving or cutting off access to these preventive services. So that bears careful scrutiny. We'll have a 15-minute break. Then following that, our third session is going to look at enhancing access to essential medications. Clearly, the issue of what medications are essential, what has improved access or enhanced it, and what is also getting in the way. Obviously, there's some things going on at CMS and Medicare with certain medications that also come to bear. And then our fourth session is going to be kind of a pragmatic kind of look at this. Why is it so hard to reduce low value care? We all have ideas about why this should be done. We've had ideas and programs and initiatives to make it happen, but it hasn't been an easy go. And so we're going to take a very careful look at that. So those are our 4 main sessions. We'll have some closing remarks toward the end of the afternoon. So that is our main agenda. With that, I'd like to go to our first session. And this is on high deductible health plans at 20 years, successes and challenges. I'm going to ask each of our 3 speakers, Frank, Stephen, and Katie, to first give us sort of name, rank, and serial number, and what is it about this panel that aligns with what you do? How do you find yourself on this particular session? And Frank, if you get us started and set a good example.
Okay, thank you, Cliff. I'm Frank Warham. I'm a general internist health services researcher at Duke University and professor of medicine. I and my team have been doing research about the impact of high deductible health plans on healthcare use and outcomes for about 20 years.
Great, thanks, Frank. Stephen.
Okay, so I'm Steve Parenti, professor of finance and also a health economist at the University of Minnesota. I have also been doing a ton of work on consumer-driven health plans, but most of my research has been looking at, in the more recent years, simulations of what would different designs of these plans look like in terms of projected budgets, nationally, take-up rates, and what they would do for a particularly vulnerable population.
Thank you very much, Steve. Those models have been very valuable. And at this point in the evolution of these plans, there's a lot of uncertainty there. And we look to modelers such as you to help us out on that. Over to Katie.
Great. Thanks, Cliff. Hi, I'm Katie Spangler with Spangler Strategies, and I'm also co-director of the Smarter Healthcare Coalition, which is a very diverse coalition based in Washington, D.C., and we are focused on increasing regulatory and legislative flexibility for high deductible health plans that are coupled with health savings accounts to be offering more high value care on a pre-deductible basis.
Excellent. Thank you very much, Katie. So I'm going to turn to Frank next, and each of our 3 main speakers is going to have about 8 to 10 minutes to kind of lay out some initial main issues, kind of the high points. We'll use the balance of our time for some Q&A and some discussion. And just, Frank, I know that these high deductible health plans they've got higher deductibles than a routine or traditional health plan. And they also have lower monthly premiums. And so how has this played out in your view, Frank?
Yeah, thank you, Cliff. Yeah, and you laid out what a high deductible health plan is. And so maybe I'll just fill in a little bit there. But yeah, I really want to talk about 2 main issues. And so, if we're talking about 20 years, first going back 20 years, and what were the open questions or the important questions about high deductible health plans 20 years ago? And second, what have we actually learned in the last 20 years from research about high deductible health plans or societal trends? So as you said, high deductible health plans have higher deductibles, lower premiums. Just want to clarify that some people consider a high deductible health plan only if it has a health savings account attached to it or health reimbursement arrangement attached to it. I think I'll take a broader definition that many people, sort of the Kaiser Family Foundation definition of a plan with a deductible of at least $1,000 for individuals and $2,000 for families. And most services are subject to the deductible. Of course, it's important to note that from very early on, most high deductible health plans had some value-based exclusions. So primary care visits and preventive care. And if it were a non-HSA, non-health savings account plan, a plan that has tax advantage dollars that you can use to pay for health expenses, those plans often excluded prescription drugs. So, and then as this audience would know, since 2010, because of the Affordable Care Act, that required evidence-based preventive care to have $0 cost sharing. So I'm going to say a typical modern high deductible health plan has a deductible of at least $1,000 and VBID features. And again, as this audience knows, this matters because about 2/3 of the privately insured now have high deductible health plans. Half of these are in health savings account plans, half in non-health savings account plans. And this amounts to about 1/3 of the entire US population. And that matters because many people are concerned, like like Dr. Fendrick's mother, that high deductible health plans will have some concerning effects, reduce utilization, and cause financial and even physical harm. So, I thought to understand the last 20 years of research about high deductible health plans, it's important to first know about the preceding research. So 20 years ago, what do we know about high cost sharing? And that's really going to boil down to understanding an important study that many here might know about called the RAND Health Insurance Experiment, because it set the stage for subsequent research and findings. So the RAND experiment was in the 70s and 80s. About 8,000 adults were randomized to very high cost sharing, very low cost sharing, levels in between. And the high level takeaways were that very high out-of-pocket cost obligations were sort of a blunt instrument, sort of reducing all types of care, whether they were needed and high value or less needed and low value. And there's an exception that high severity emergency department care didn't decline as much, but in general, all services went down. Because of this, high cost sharing was found to reduce healthcare spending. No surprise there. If you reduce the use, you're going to reduce the spending. And then a third major takeaway from that study was that there was no observable impact on health outcomes, except for a subgroup of people who were low income and high morbidity. So they were predicted to have adverse health outcomes. I think it's also important to know that 20 years ago, we didn't have research about this modern sort of high deductible design that has value-based exclusions. That just wasn't part of the body of research then. So I thought I would raise sort of 7 major questions about high deductible health plans that existed 20 years ago. And several of these questions were raised by sort of the RAND health insurance experiment. Would these play out in the modern high deductible environment? And other of these questions were raised by high deductible proponents and high deductible critics. So let me go through these questions, and I'll try my best to summarize what I think the answers or lack of answers we've gotten over the last 20 years. So these first 3 are really sort of related to the RAND health insurance experiment. How will that play out? So will reductions in service use among high deductible health plan members be indiscriminate, sort of this blunt instrument, or will patients distinguish high from low value care? And I think it's been very clear, actually, that when you have exclusions of high value care, such as cancer screening, prescriptions, cholesterol testing, diabetes monitoring, when those are excluded from the deductible, sort of a value-based exclusion I talked about, those are preserved. I've seen many studies, I've conducted many studies that have shown that those types of services, those high value services, are preserved when they're excluded. Interestingly, maybe less well known, there's also a pretty good evidence that high value care is preserved even when it's subject to the deductible. We've done studies about people with bipolar disorder preserving psychiatrist visits, cancer patients preserving oncologist visits, diabetes patients and HSA plans preserving specialist visits. Now, this isn't always the case, but that's a lesser known, I think, phenomenon under high deductible health plan. On the other hand, we do see that maybe people might be, there might be offsets. People might be reducing other forms of care to preserve the type of care that's important to their major health condition. And I'll also say that it's also clear that there are reductions in high value, expensive care, medications. Many studies have shown that medications decline when they're subject to these high deductibles. Okay, so second question, sort of related to the RAND health insurance experiment, will high deductible health plans reduce healthcare costs and premiums, Or will the potential harm that they might cause lead to no cost savings or even increased costs? And then here I might defer to my economist colleagues, but I think research here has been pretty clear that high deductible health plans do reduce healthcare costs. You see estimates in the range of 5 to 15%. So modern high deductible health plans are associated with reduced healthcare spending. Okay, third question related to the RAND experiment. Will high deductible health plans worsen health outcomes broadly or not at all, or among lower income and chronically ill patients only, as predicted by the RAND health insurance experiment? Here, I think we have a sort of not a lot of research. There's been a handful of studies. We found in a study that there was no overall impact on major adverse cardiovascular outcomes among sort of a broad population of people with cardiovascular risk in high deductible health plans. On the other hand, we also found that high deductible health plans are associated with increased acute diabetes complications and high severity hospitalization days among low income diabetes patients. So that's three questions. The next sort of four questions I want to talk about were sort of hopes or expectations raised by proponents of high deductible health plans. So let's see how those played out. So fourth, will high deductible health plans facilitate the expansion of health insurance? Those of you who are familiar with the employer-sponsored market might know that especially small employers often face a choice of having either no health insurance or a high deductible health plan because they have lower premiums. So one could argue that high deductible health plans have helped preserve health insurance coverage among especially those smaller employers, although others would argue that that's really kind of an expansion of underinsurance for those employers. And then the Affordable Care Act really expanded health insurance at the state level through high deductible health plans. The state marketplaces that were set up really sell high deductible health plans. So, and there were other provisions in the ACA, like the Cadillac tax, wasn't enacted, but that were really, it seems, meant to promote the expansion of health insurance through less generous high deductible health plans. Fifth question. Will high deductible health plans enhance price awareness or even financial toxicity awareness and price transparency? I think we've all seen the popular media stories about health cost shocks, the cost of drugs like semaglutide, insulin, EpiPens. We've seen legislation like the No Surprises Act, insulin out-of-pocket caps, executive orders like the hospital price transparency rules. So I think it's fair to say there's been a lot of publicity and policy interest in prices. And, I think you could attribute a good amount of that to the prevalence of high deductible health plans where people are just seeing their out-of-pocket costs a lot more than they might have in the past. Sixth question, again, this is related to, some of the predictions of proponents. Will high deductible health plans promote value shopping and therefore price competition among providers? I don't think there's been a lot of research here. I only know one study, and it really didn't show evidence of value shopping. And just looking at the situation as I see it as a clinician and as a researcher, in the current conditions, I'm not optimistic that value shopping and price competition among providers will happen because of high deductible health plans. And seventh and final question, will people in high deductible health plans improve preventive care and improve their health in an attempt to reduce out-of-pocket costs? This was one of the arguments of some proponents, and I can pretty confidently say that the answer is no. Here, I haven't seen a high deductible study that shows that people became healthier or used more preventive care. Okay, so what do we know about high deductible health plans in 2024? Let me summarize all of what I just said briefly into four basic realms. So the behavioral response of members to high deductible health plans. I don't think high deductible health plans in the current form are a blunt instrument. Patients do respond to the VBID features. In terms of needed or appropriate care, that's subject to the deductible, we do sometimes see preservation of even these services, but on the other hand, we see concerning reductions and offsets in other types of care. So that's sort of a mixed picture. Effects on patient health. There's no evidence that high deductible health plans make overall population sicker. But on the other hand, they don't make members healthier, and they might worsen health outcomes for low-income, high-morbidity patients based on existing research. Third, effects on costs and coverage. High deductible health plans reduce healthcare costs and therefore facilitated the expansion of health insurance. But some would say this is really just the expansion of underinsurance. And then fourth, the promotion of optimal market conditions. There's certainly been increased societal and policymaker awareness of health healthcare prices, but it seems unlikely that high deductible health plans are promoting value shopping and therefore price competition. So that's my take.
Frank, that ain't a bad take. You covered a lot. The conclusions that you just derived and summarized came from examination of 7 questions. We really appreciate that coverage, distinguishing between high versus low value care. Do they reduce spending? Yes, no. What about the outcomes? Do they expand health insurance or not? What does it do to price awareness and toxicity? Do they value shop or not? And do they improve preventive care? And the answer to that one was no. So that is a wonderful overview. Really appreciate that. We're going to come back to some of those points, I think, in just a bit. Thank you, Frank. Steve Parente, we're going to move over to you. And how do you kind of think of this in terms of the modeling universe, Steve?
Well, thanks, Cliff. This has been a fun journey for me. Actually, for me, this is about a 24, actually, if I really count it right, about a 26-year journey. I actually studied these when they were medical savings accounts, when they came out of back with HIPAA. And interestingly enough, I wasn't at the University of Minnesota. I was at Project Hope Center for Health Affairs at that time, later NORC. And we got a giant study from the GAO to say, what's going to be the impact of these brand new medical savings accounts? And we had to give the money back to GAO because no one signed up for them. So that was my first foray into this space. Later, moving to Minnesota, the nice thing about Minnesota is that, particularly the business school, is that we have a lot of innovative ideas that come out of here. HMOs, with going back with the designs that came from Paul Elwood, came from Minnesota. United Health Group came from Minnesota. And all the stuff that comes along with it. But more importantly, Definity Health and Luminous and a bunch of other firms that were startups in this space in the 2000s were things I started to track. And they let me actually look at all of their major employer data funded by RWJ to figure out, first of all, whether or not there'd be adverse selection problems in terms of what was going on. And actually, the RAND health insurance experiment that Frank mentioned was key on our mind. What was interesting was that the developer of these plans also read the RAND health insurance experiments. They were former students that actually learned about that stuff, and they made primary prevention required to actually be in the benefit design and Definity to avoid the issues that the RAND health insurance experiment talked about. So one thing we also found when we looked at selection was that it turns out that chronic conditions were not the thing that everybody thought would keep people away from these plans, at least initially. It was actually income would be a correlate of whether they'd go into them or not, actually. And it was a different design. It was a much more generous HRA design. Matter of fact, we tracked them long enough to realize in the case of one very large employer, a tech company, they actually made their design so generous that it actually was creating a moral hazard problem for their plan design. And they actually had to increase their deductibles to get things under control. Wow. Now, those are your grandmother's high deductible health plans. Today, they're much more tighter in terms of deductible limits and co-insurance. Just to give you a perspective, that one employer I mentioned had every family got an account of $2,000. This was in 2002, and the deductible threshold was at $3,000. So their donut hole was $1,000. That's not a big donut. So one thing that came out of those studies was we had a ton of choice information, knowing how people would choose these different plans. And lo and behold, the MMA created the health savings account market. We actually got a study paid for by ASPE at HHS to forecast what might happen if these were entered into the market. There were lots of speculation in 2004, the first plan offering year. And my team with Roger Feldman, John Christensen, Minnesota, we actually came pretty darn close. We forecasted about 2.4 million people would enter the market. It ended up being about 2.2 in that first year. Many people were off by 1.5 million, I think, from one other studies I saw from other places. One reason why we were thinking that we had a pretty good model was that we were factoring in all the right economic inputs, chronic conditions, whether they had them or not, whether or not what their income level was, so SES status. So it's a much more complex model than what normally would have for those choice variables. And then subsequently, we used that actual complex model to model a lot of other things that would happen in this plan design, which gives me to chapter 2. I know Katie will talk about some of the tax changes that were made. One of the big concerns about these high deductible health plans was that they did not have anything for folks with chronic conditions, particularly diabetes, asthma, depression, and other things. So actually working with folks from the VBID Center going back now, actually over 10 years, we tried to model what would happen if we inserted that as a new benefit design, if we actually made secondary prevention, that is basically pre-deductible paid care for folks with diabetes, with asthma, and got specific, actually figuring out what's the PMPM cost and the premium, factor that into a new model, see what people would move it differently. We actually had to make some pretty big assumptions about perturbing some of our variables of folks with chronic conditions, see whether they would move one way or the other, given what their choice sets were. And so in the end, we actually used that work to, at the very least, come up with a prediction that it would actually save money and more people would move to what we call an high deductible health plus model market. As I mentioned, Katie will talk about what the outcome of that is, but basically that model was just by coincidence in my hand in 2019 when I worked in the White House, and someone from HHS said, there's a proposal moving around Treasury. They want to have a price point to understand what things should be included in the parts list for this new legislation, or actually rule change, that will come from Treasury guidance. And it just so happened we had the parts list with PMPM to see exactly what would be there. And we actually knew. So I pulled out my old results going back to 2018, right before I was in the White House in 2019, just to basically say, like, different models, whether everybody replaces them with these designs or off them side by side. And it turns out the number that we came up with, what the truth was half the plans offered these new designs ended up pretty darn close to the truth in terms of the take up and who would actually get into those markets. Not quite as good as our 2004 Health Affairs study, but not that far off either. What I'm working on now is imagining a world where we can expand that coverage. What if we actually made secondary prevention even more expansive than what it is now? Well, that was one of the complaints that came out in 2019, was that it should have been more expansive than just the list that we had. And so I've been working to add more drugs in there, particularly for chronic conditions. Also adding full primary care for folks with chronic conditions as well. And then even the provision of direct primary care as another component. What we're finding is that adding those pieces into premium, from what we heard from experience, is not that expensive compared to all the other components of what's going on into the market. What we see is what you would expect. More people will gravitate towards those types of plans. What we're missing, and this is for the question for the future, myself, whether it's Frank or others that are there, is what is happening in these plans. We know that people are selecting these new types of, if you will, high deductible health plus designs. What we don't have is the claims detail information to tell you what the RAND folks found before, what I found before, about whether or not costs are moving up and down, are health outcomes being affected, are people getting more of the services that they need, and we track them longer term to see modifications in behavior that we would expect in that space. It's the ideal world, and actually I'll make the offer to anybody on that's watching or anything else. It works best if this is coming from employer data. You need to have employer data that includes the full benefit choice set, so we know what the alternative choices are that they're choosing against, and the claims data that goes along with them. I've had 30 years of handling sensitive data. I'm good at it. We've never had a breach, but that's the best way, whether it's my shop, Frank's shops, anybody's shop, to try to figure out definitively what these new designs are doing, which I think are quite empowering. And then the last thing I'll mention, 15 seconds to go, is when we talk about all the price transparency stuff that's in the future that needs to be there, that has to be layered on as well. We don't know yet what these tools might do. The most limited thing we ever found from our previous work was that if you tell folks the pharmaceutical prices, they will go down. But we don't have the tools yet to see the full picture. And with that, my voice is gone.
Well, Steve, your voice ended just in time because you had, I think you laid out a half a dozen great issues here for further consideration. It's so interesting how the RAND experiment has had such a long tail insofar as its influence since, I think the first report I saw of it was 1977. It's been a while. You got into choice making and the nuances around that. You emphasize the role of secondary prevention of chronic conditions, which is an increasingly important role. You talked about how you might even model expansion of secondary prevention, where they're adding drugs, full primary care as well. You emphasize the role of employer data, and Katie might be one to comment on that as well. And then you talked about price transparency. What's it really going to look like? It's hard to know what kind of impact it might have if we don't kind of understand how that's going to roll out. So Steve, great points. So Katie, both Frank and Steve have put some things on your plate now. Both of them referred to stuff Katie's doing. And I know you're going to talk about some survey data and some other findings, expansion of the preventive services. What do you have for us, Katie?
Great. Thanks, Cliff. And maybe just one more second on my background. So I actually was working in the United States Senate in 2003 when the Medicare Modernization Act was passed, which had this section that created health savings accounts within the US tax code. So for the past 20 plus years, I would say I have been working on health savings account issues. A lot of the more recent work, I would say in the last decade, has focused on expanding what can be offered on a pre-deductible basis. And so was delighted with the progress that we made thanks to Dr. Fendrick's leadership, Dr. Chernu, as well as Steve Parente, to really expand what could be offered pertaining to chronic disease prevention. So when the law was created in 2003, as folks know, there was a safe harbor for preventive care. But when those regulations were published and that sub-regulatory guidance was published in 2004, there was actually a very narrow definition of what constituted preventive care. And so we worked for over a decade to expand that list to include more chronic disease prevention, because previously the rule had been that if you could screen to find out if someone had a disease, but once the diagnosis was made, anything to treat that condition could not be provided pre-deductible. But given kind of all the data that we have talked about on this call already, our country spends $4.5 trillion on healthcare every year. About 90 cents of every healthcare dollar is used to help manage chronic conditions or treat chronic conditions. So if we can do a better job of that on the front end, you can imagine just the potential savings that could accrue to the system, not to mention if a patient with a chronic condition is better enabled to manage their chronic condition, their entire way of life is going to be drastically improved. And so this really is an example of a 1 + 1 = 3 in my mind, just policy goal as far as expanding what can be offered on that pre-deductible basis. So we said for several years, going back several administrations, we kind of made the case of if you build it, they will come, or if we build it, they will come. We had said that if employers and health plans were granted more flexibility to offer additional chronic disease prevention pre-deductible, that they would do it. And we said this a lot. We said it early, we said it often, we said it over multiple administrations. We were delighted that the previous administration took us up on that, and they did expand, as Steve mentioned, to allow 14 additional drugs and services to be offered on a pre-deductible basis. That was in 2019. That guidance document is Treasury Notice 2019-45. And we then spent the next couple of years trying to understand exactly what happened. And, we knew we had said this and we wanted to see if we were truthful in what we had said. And so the Smarter Healthcare Coalition, of which I am co-director, partnered with America's Health Insurance Plans, or AHIP, who is a member of the Smarter Healthcare Coalition. They surveyed their members who represented both fully insured health plans, but also in partnership with employers representing self-insured health plans. And what they said is that after the survey data came back in, we saw that between 75 and 80% of health plans and employers actually changed their benefit designs to offer more chronic disease prevention pre-deductible. So we were very delighted with that finding. I'll never forget Dr. Fendrick politely and kindly encouraged me to not get too excited because he was a little nervous that maybe those results wouldn't hold up. So you can imagine my delight when about a month later, the Employee Benefit Research Institute and the great work of Paul Fronston affirmed that result with his survey results, which showed that 76% of responding employers made changes to offer more chronic disease prevention pre-deductible.
So Katie, can you just say that one more time? It's such a key finding. Can you capture it one more time in kind of a kernel?
Yes. So between 75 and 80% of employers and health plans that responded to the surveys made changes to offer more chronic disease prevention pre-deductible for their employees.
So definitely kind of a cause or intervention and impact directly tied, correct?
Correct. And we drilled even further, Cliff, and we asked them, okay, so which things did you offer? the majority of respondents said that they offered things to help manage diabetes pre-deductible, which, many folks are aware how tough it is to live with diabetes. And so for the patients with high deductible health plans, that's a terrific benefit for them. And then second up was heart disease. And so also really important and really prevalent in society. So those two findings alone were very helpful to know. Paul Fronston in his work through eBree also asked employers, if you were provided additional flexibility, would you utilize it? 81% of respondents said yes. And so that's another thing that we're really working, and I think adds a lot of wind in our sails as we work to expand what could be offered pre-deductible. And so as part of that 2019 guidance, Treasury and IRS said that they would look to update the current list of 14 items and services, that they would look to update that every 5 to 10 years. We are now 5 years out. And so we have been knocking on the door for over a year to say, hey, remember us? We pushed you to offer more chronic disease prevention, or to allow coverage of more chronic disease prevention pre-deductible. It happens, between 75 and 80% of folks actually did it. We would really love for you to expand the flexibility to additional high value services. And so that would include things like mental and behavioral health counseling. I think certainly coming out of the pandemic, we've unfortunately seen the need for additional mental and behavioral health counseling. Additionally, things like naloxone to treat drug overdoses. Also very interested in some primary care visits being allowed to be offered pre-deductible, as well as even potentially specialty visits. One thing that we have heard from survey respondents is that it's difficult sometimes for a patient. It's great that their insulin could be offered pre-deductible, but if the visit for the prescription for the insulin is not pre-deductible, that erects a new barrier for some patients. And so we would love to see some of those primary care visits be able to be offered pre-deductible. Cliff, I could go on, but I don't want to forestall conversation and discussion.
No, those are great points. And again, the impact on the employers and the fact that they really took these findings to heart and actually acted on them in short turnaround is important. And you substantiated the point that Steve made about how important employer data are. So that's a big idea. Insofar as the last 20 years, we've learned about who responds to what kind of stimuli, and those are good lessons to take home. I'm wondering, Frank, having heard what Steve laid out from a modeling standpoint and expansion of secondary prevention, what Katie just pointed out insofar as employer responsiveness, how might those findings or trends affect your work and what you're looking forward to?
Yeah, that's a great question, Cliff. Interestingly, we kind of already know in some sense. There's as I mentioned at the beginning, high deductible health plans for many years have excluded certain services from the deductible. Now, those aren't the HSA, although not necessarily the HSA eligible ones. High deductible health plans that aren't HSA eligible will exclude certain services from the deductible. And I have to say, even HSA eligible ones, there's some gray area around whether medications could be offered pre-deductible. And so some major national health insurers were offering medications for secondary prevention of chronic illnesses pre-deductible. And so, we've been doing studies about that. And we recently published a study showing that when an employer purchases one of these plans that make a whole large list of preventive medications $0, that not only increases use of those medications, and that's sort of the VBID finding, but it also improves diabetes health outcomes. We found an association with reduced days that people experienced acute preventable diabetes complications when they transitioned to a plan that made their medication $0. So, and then there's been pretty clear findings that when you transition to a high deductible health plan that keeps a lot of those preventive services that Katie's talking about, not subject to the deductible, sort of low costs, those are preserved. So my reflection is that that the efforts on behalf of HSA plans are probably going to be successful in preserving care and hopefully improving outcomes. And that's what we've seen in sort of early studies about that type of design.
Excellent. Steve, in your modeling work, whether it's secondary prevention or otherwise, to what extent are you able to model or forecast the impacts of things like GLP-1s and naloxone for opioid use disorder and other technologies coming along? Are you able to sort of accommodate those, and do those have any meaningful impact on your modeling, your model findings?
It depends on the overall price. So for the GLP-1s, it definitely could, because if you think about some of the things that we're talking about for adding, say, primary care or mental health in terms of what's the PMPM impact on that, they're present, but they're not that significant. Right now, the GLP-1s, as they are on brand, with Ozempic the way it is right now, I mean, that would have a major impact. It's sort of like the same way when the Hep C vaccine first came out. I mean, that almost blew up the the secondary risk market. So yeah, I think that one illustration might be a little bit off, but if something that's more common, not a blockbuster drug that's sweeping the nation, then I think it would be different. Now, the question is to what extent, and I teach a pharmaceutical policy class, so I need to answer this question before Saturday, but to what extent we have the substitutions for GLP-1 or other things that are available that could lower the cost is a different issue. I know a lot of people are getting them through compounding, which is not what the compounding laws or restrictions are supposed to be doing for. So there's lots of, the question is whether or not the outcomes really justify what's going on there, whether they could be factored in. But yeah, that should be probably something that would be added to the list, as long as it doesn't blow up the model and the outcomes justify the long-term impact.
And you probably have to be aware of kind of how prices would change given the market factors and so forth. Right. Katie, can you sort of come back to the issue of how secondary prevention is viewed by policymakers and legislatures and so forth? Do they get secondary prevention, or is it still seen as something, well, you've had a problem diagnosed, this is about treatment, not prevention? Is that still an issue?
Yeah, so I think that there is a deepening understanding of the importance of addressing chronic disease, right? So I think of secondary prevention as, if primary prevention is screening to find out if you have the disease, and if secondary prevention is actually treating that chronic disease, I do think that there is an increasing emphasis on this. As I mentioned, right, the CDC has estimated that about 90 cents of every healthcare dollar is used to manage chronic disease in some way. And so certainly Congress understands this, especially with regard to the Medicare program.
They do? Okay. Mm-hmm.
And there have been a lot of different bills really targeted at Medicare spending and trying to do a better job of helping Medicare beneficiaries with chronic disease. I think kind of the work that the Smarter Healthcare Coalition has done in partnership with the VBID Center is really to broaden that work and make it also applicable within the commercial markets. And where we've seen probably the biggest barrier to flexibility with benefit designs pertains to plans that are coupled with health savings accounts.
Okay.
Some folks have asked, like, why are we focused so much on high deductible health plans that are coupled with health savings accounts? And that's because those are the plans that are regulated at the federal level by Treasury because of the tax implication of the health savings accounts, right? And so health savings accounts are the only thing in the tax code that have the triple tax advantage of you're able to invest in your health savings account on a pre-tax basis. The amount that's in your health savings account can grow tax-free, and then you're able to withdraw those funds without paying taxes on them. And so there's no other kind of unicorn within the tax code that has all three of those tax advantages. And so that's why these plans, the high deductible health plan in which you have to be enrolled in order to make or receive a contribution to a health savings account, those are pretty closely regulated by Treasury and the Internal Revenue Service, because of that connection to the tax benefit. And that's where really the barriers have arisen with regard to implementing more value-based care and value-based benefit design, and especially on that pre-deductible basis, because they're regulated so heavily by Treasury and IRS.
God, it's interesting you're saying that, because Adam Finkelstein just asked about the status of health savings accounts, and I think you got into that very nicely. And I have to say that we got a question, maybe a bit of a tongue-in-cheek question from David Kendall, said, hey, why not make the GLP-1s for weight loss pre-deductible? There's something to mull over for you, Steve. Question back to Katie, having to do with the employers. Monica Van Buskert asks, what kind of flexibility would be appealing to employers? Did you learn what else they're interested in expanding? So giving some employers some leeway. What do you think, Katie?
Yep. So we did ask that question. Overwhelming response pertained to the primary care, kind of an office visit. So either a primary care visit or maybe even a specialty visit, for example, to an endocrinologist if someone has diabetes, or a cardiologist if someone has heart disease. We also heard about telehealth and the strong desire to continue to be able to offer telehealth on a pre-deductible basis. I'm delighted to say that there is current flexibility to offer telehealth pre-deductible in these health savings account eligible plans. But the bummer there is that that flexibility ends at the end of this year. This was something that cropped up in response to the pandemic. It was in the CARES Act that passed in March of 2020 to grant flexibility. Congress has renewed it several times. I do expect that they will renew it again, but I will say it's a little tough if you're an employer and you're planning your benefits. You know, you don't wait until Congress passes something in December to really plan your benefits for the next year. And so that's why there's a big push to make some of that flexibility to offer telehealth pre-deductible, to make that permanent.
Got it. Question for Steve, although others can comment as well. This came in from Chris Saxman. It has to do with these things starting to look a little bit like MA plans. And so these additional services that Steve and others have described sound like supplemental benefits that Medicare Advantage plans offer to compete. Can there be any comparison between these two realms for analytical purposes? Steve, you have a take on that?
Yeah, I mean, it could be. I mean, there's obviously a choice model in terms of people choosing a more traditional path. So you could think of, I'm going to take a standard old PPO versus take a high deductible health plan market, assuming the employer offers both. There's a lot of employers that don't offer both and offer just one choice, full replacement, for example. But I mean, I think there is a difference. I mean, some of the things offered for MA are really extensions of social services. We're not proposed. I mean, some of the things, maybe the counseling stuff that we're modeling as the new models sort of get there. But most of these things are generally thought of as they're in medical care. They got CPT-4 codes or they got NDC codes. They're not necessarily a special transportation service or something else like that to get folks to doctor's appointments. I think they typically fall in that realm to be qualified medical expenses.
Got it. Got it. Question here from Risha Gawani, and this is a little kind of heavy here, but it has to do with favorability towards HDHPs that have with HSAs. So wants to hear the panel's thoughts about why, follow me now, why so much proposed legislation favors exempting services from the deductibles of HDHPs with HSAs when there are a large amount of people enrolled in plans with greater than 1,400 or 2,800 deductibles, yet don't have HSAs, who then don't enjoy the benefit of having services not subject to deductibles. Why, and that's being posed here, why are HDHPs with HSAs being favored so much relative to other HDHP plans? Frank, do you have a go on that, a take on that?
Yeah, I do. I mean, that's a little nuanced, right? But
it is.
What's happening with the health savings account plans is, as Katie and Steve mentioned, they're regulated by the IRS. So they require everything to be under the deductible. Let's start with that. Everything has to be under the deductible. The original provision said primary preventive services, like primary prevention, not secondary prevention, could be excluded from the deductible. And then what Treasury 2019-45 said is 14 more things could be excluded from could be made pre-deductible. It's not saying they were required to be. So I mention all that because health savings account, high deductible health plans that don't have health savings accounts are not regulated. So if you're a large employer, you're purchasing from a large national health insurance company, you could get a high deductible health plan that does have all these things already exempted. So it's the push that Katie is trying to do is to say, let's at least get high deductible health plans that have health savings accounts even allowed to exempt these things from the high deductible. And I think that might be where the effort isn't to say, let's make these things free under the deductible. Now, employers can do that, but it's to say, let's just it's not requiring them to be free or low. It's just saying that they can be. So that's, I think, the nuance. Katie and Steve might have better ways to explain that.
Katie, you have a take on it as well?
I do. So I think this is a really important distinction, and I'm so glad that you answered the question as you did, Frank. So the work that the Smarter Healthcare Coalition has been doing, to Frank's exact point, is really to just allow the flexibility to offer more chronic disease prevention pre-deductible, right? So we're not proposing a mandate. And I think that's also what's so important about those survey results that I mentioned earlier. There was not a mandate that you have to offer insulin pre-deductible. There was just we removed the barrier that said that before you couldn't offer these things pre-deductible. So we just said, hey, employer, health plan, you know your populations most likely pretty well, and you know what should be offered pre-deductible and what will benefit your populations if it is offered pre-deductible. And so that's why it's so, I think, remarkable that between 75 and 80% of employers said, you know what, we're going to use this flexibility and we're going to decide to offer it pre-deductible. And for the most part, they did not charge cost sharing. Some people did charge cost sharing. They still had that option. But the key there was that because these plans are so regulated by Treasury and IRS, we just wanted the flexibility. And that was what we were advocating for. I think, and why we're focusing on this so much is because, you know, a PPO plan or a plan that has ended up having a high deductible, but is not technically coupled with a health savings account, they already have the flexibility to offer what they would want on a pre-deductible basis or to carve certain things out of the deductible. But the HSA eligible high deductible health plans are the ones that for which we really needed to be granted that flexibility by either Treasury through the guidance, or there are also legislative endeavors underway as well.
Got it. Great answer to that question. Jerry Kluel has a couple of questions about PBMs. I'm not going to get into all the details there, but basically, Jerry's saying, can PBMs kind of game the system here insofar as high deductible health plans and so forth to kind of offload some of their financial risk? And by the way, are there any efforts being undertaken to pass discounts from list prices to consumers with full transparency, which does not exist today? So can any of you kind of comment on where PBMs sort of kind of arrive into this space and what impact their key industry role might have? PBMs. Steve, what do you have? What do you think? Do you kind of model PBM's role in this?
I have not usually, because usually I focused on more the medical care side of it, more so than the PBM component. But that said, it really will depend a bit on if it's employer sponsored, how is the pharmaceutical benefit managed? What's the separate PBM contract? I mean, I, for example, am in a high deductible health plan through my university. I practice what I preach. And so, but the PBM design is almost entirely excluded from that high deductible design, the way that they've set it up as an employer-sponsored plan. Whereas if you wanted to take it strictly in the sense of insurance, it shouldn't be actually. So it does, I think, depend upon how someone wants to deploy in the self-insured ESI world. That said, in terms of the rebates and passing them discounts, hard to say without having that data to see exactly what would go on in that space. That's really a benefit design manager question more so than an economist.
Well, when you're thinking about behavioral response, to the extent that patients, including many with chronic diseases, have choices to make about very expensive drugs and whether
Right.
they're, pre-deductible or not, what the out-of-pocket costs are, payments and so forth. That's got to affect their broader behavior as well for what healthcare they seek and so forth.
I would, well, again, quick comment. I mean, if the plan is selecting, for example, for the provisions that came out in 2019, we have things in there for SSRIs for depression and things like that. That would mean that they should either have very little cost sharing or no cost sharing, and that would translate through to whatever their PBM model would be. It should be, if that's how they want to, enact it. But again, to Katie's point, and Frank's, it gives them permission to do that. It does not require them to do that. So,
point well taken. Good, thank you. I want to give you each a closing question. Please answer in less than a minute, and 30 seconds is even better. So, Steve, Katie, you've been in this, as you've just said, more than 20 years each. Frank, you've been racking up a lot of time and studies as well in here. What should we now look for? What should we look for? Your audience should be watching out for with regard to high deductible health plans, insofar as what they're going to look like 2 years or 5 years or more. Watch this space. What should they have their antenna out for? Frank, we'll start with you. What should I be looking for insofar as what happens to the HDHPs over the next several years?
Well, as a researcher, I'm going to say follow the evidence. There's good studies coming out about the effects of high deductible health plans on increasingly sort of smaller and more vulnerable populations. And if we find that those populations are at risk, let's get the benefit design, the evidence-based benefit design that takes away that risk. So I'm going to say follow the evidence about high deductible insurance.
Follow the evidence. Thank you very much, Frank. And over to Steve. What should we watch out for, Steve?
Two things quickly. I mean, again, to Frank's follow the evidence, the GLP-1 question is going to be kind of interesting. There should be claims data to see who's getting it, what it's doing, what outcomes might be there. It'd be hard to actually get the full EHR data, but I mean, that would be something to look out for the next few years. And the second thing is price transparency. The insurers are now releasing that data. It's there to be harvested by a bunch of .com folks that can eventually put it into apps. No one's really gotten it there yet. But the necessary but not sufficient condition has been met for them to do it. And so the question is, let's see what happens.
Got it. Thank you very much. Katie, what do you think?
Yeah, I like the follow the evidence theme. About 70 million Americans are in these high deductible health plans, if not more. That's the ones that are coupled with health savings accounts. And so I think that's a lot of people. And I think the evidence of how much we spend as a nation on chronic disease prevention, I feel pretty good about the odds that we're going to be able to expand the list of things that can be offered on a pre-deductible basis to include more high value care. And so I feel optimistic about the road ahead.
It's good to have that note of optimism. So across the three of you, everyone agrees on following the evidence. Watch to see what happens and how price transparency rolls out, and track carefully the spending on chronic diseases and chronic disease secondary prevention. All three great things. Well, Frank, Steve, Katie, great start to this. You hit on all the notes we needed from you. We know where to find you. And there's some other questions we didn't quite get to, and I think that VBID will be tracking those as well. Thank you all three very, very much. Thank you so much.
Thank you, Cliff.
All right, you were all three great. Great. Thank you. All right, we're now going to move to